Hi, everybody. Good evening. It's my pleasure to be here with some wonderful colleagues of mine. Thank you so much for attending tonight's Ask the Experts virtual event, Keeping Your Heart Healthy. I'm Dr. Tamanasi, a cardiologist here at the Cleveland Clinic. And as I mentioned, joining me are specialists from Cleveland Clinic Seidel and Arnold Miller Family Heart Vascular and Thoracic Institute. Cleveland Clinic's heart program has ranked #1 in the nation for 27 years, and we have office locations throughout the Northeast Ohio region and beyond to meet your needs. We're here tonight to answer your questions, share our expertise, and provide clinical insights on several things, including steps to reduce your risk of developing heart issues, when to see a heart physician, pandemic habits that may have had a negative effect on heart health, what to do if your family has a history of heart disease, and then how to recognize heart attack signs and symptoms. We've had more than 400 questions submitted by our audience, and so we'll do our best to answer as many as we can this evening. We'll also send out an email after the event that includes heart healthy resources. If you still have questions after, please visit clevelandclinic.org/heartnurse to contact one of our registered heart nurses who can help you learn more about your condition and treatment options and also help you choose the right physician. So with all that said, let's take a few minutes to do some introductions of our esteemed panel, and then we'll go ahead and dive right into the question and answer portion of our event tonight. So again, to just kick things off, I'm Dr. Tumana Singh. I'm a cardiologist here at the Cleveland Clinic main campus, and also tonight's moderator. So just a little bit about myself. I've been here in Cleveland for about 4 years. I'm the co-director of our Sports Cardiology Center. So I take care of professional athletes here in the region, as well as nationally, our collegiate athletes, as well as our recreational and highly active individuals. We kind of run the gamut with respect to athletic care and active people. We do pre-participation screening, evaluate and try to advocate for individuals who are trying to maintain exercise habits while they are dealing with certain cardiovascular illnesses. And that's actually one of the most common questions and referrals that I get, exercise recommendations and what to do, perhaps within the quote unquote confines of a specific cardiovascular illness. Alongside that, I work with the Recover Clinic, which is our clinic that manages our post-COVID syndrome individuals. And so I do see a number of individuals who have symptoms manifesting from post-COVID. And so, I think that's kind of where I'll leave it at for myself. And I'll go ahead and introduce our next panelist, Dr. Like. She's our clinical cardiologist over at Akron General. Dr. Like, if you'd like to go ahead and introduce yourself.
Yes, so I've been with Cleveland Clinic Akron General for 4 years. I do a lot of general cardiology, take care of patients with heart disease, stents, bypasses, valvular disease. My special interest is in cardio-oncology, which takes care of patients who have developed heart disease, some type of heart disease due to either cancer itself or due to treatment from cancer, such as chemotherapy and radiation.
Great, thank you so much. Dr. Martina, would you like to go ahead and introduce yourself? She's actually our medical director of the cardio obstetrics over at Hillcrest Hospital, and also based out of Beechwood Family Health Center. Dr. Martina?
Yes, thank you. I'm so happy to be here with you tonight. As Tamana mentioned, I am the director of cardio obstetrics at Hillcrest Hospital. So I have a special interest in cardiac complications that may occur during pregnancy and other things that may increase your risk of heart disease later in life. A lot of times these can be hypertensive disorders in pregnancy, like eclampsia, preeclampsia, or the HELP syndrome. Also, conditions like preterm delivery or low birth weight, we actually see that there is some increased risk of heart disease prematurely in these women. So we try to screen for them through our postpartum program, and we have an integrated program of cardio obstetrics with anesthesiologists, our heart failure doctors, general cardiologists, maternal fetal medicine, and OB physicians who manage high-risk pregnancies and deliveries throughout the pregnancy. So we meet with them often in a multidisciplinary fashion and sort of determine what is the safest route for them to deliver, where they should deliver, how and when, so that we can keep our women safe, because maternal mortality in the United States is on the rise and unfortunately affects many disproportionately in underserved communities. So that's a deep passion of mine.
Wonderful. Thanks so much for sharing, Dr. Martina. And last but not least, we have Dr. Patisapu, who is one of our clinical cardiologists over at Avon Hospital. Dr. Patisapu?
Thank you for having me today. I am Dr. Anish Patisapu. I primarily work at Cleveland Clinic Avon on the west side of Cleveland, also some time at Fairview as well. I've been here for the past year. Prior, I did my training at Indiana University with residency in cardiovascular fellowship. I'm a non-invasive cardiologist. I treat all adults from 18 up. My primary interest is in older adult population. We have a lot of cardiovascular advancements that have been coming out lately, and my goal is to ultimately bridge the connection between quality of life and quantity of life in the cardiovascular aspect, and I enjoy that here at Avon. Thank you.
Great. Thank you so much, Dr. Patisapu. So all of you have now met our panel, and I think it's time to dig into some of these questions you guys have submitted. So we'll go ahead and get started with our first question, which is directed towards Dr. Mattina. So what are some signs that you should have your heart checked by a doctor?
Well, I think some of the signs that we're looking for are strain on the heart, and there are many things that can cause strain on the heart. That can be rhythm problems when your heart is beating too fast or maybe too slow, or potentially in an irregular heart rhythm. So if you're feeling palpitations or skipped beats frequently, again, our heart is not perfect. There are times when we may have a skipped beat or a little flutter. We're really looking for something that's happening daily or several times a week, maybe prolonged episodes, or a pattern that it may be progressive. Maybe it used to be every 3 months and now it's mostly every other day. So that can portend some rhythm problems that we may want to investigate. When we talk about blood flow to the heart, usually we're going to have symptoms that show increased demand on the heart where our blood supply is not adequate when we're exerting ourselves. So if you're trying to exercise, or some people notice when they go upstairs or uphill, or they're not able to play tennis or other sports like they used to because they're feeling too fatigued or short of breath, those are signs that maybe there is some strain on the heart and the blood flow may not be adequate. That can be for other reasons like anemia or thyroid problems too. So we want to make sure that we have a thorough workup and we're looking from head to toe and trying to fit it together for what the patient needs.
Thanks so much, Dr. Mattina. I'm going to open it up to our panelists as well. Anybody else have any comments on how to really figure out, is something going on with the heart, or are you just kind of making things up in your mind? How do you know?
I think it all depends on how much we get from the patient. It all boils down to, how many questions we are asking. Is the shortness of breath associated with more chest pain? Do you have more palpitations? Are you also feeling dizzy? Most of the patients, if you talk to them in a lot of detail, they will give you clues that would actually direct you in terms of workup. It will actually pin it, narrow it down to at least 2 or 3 things, and then we can always rely on our workup to get the definitive answer.
Dr. Patisapu, any comments on your end?
Yes, I agree with both of them. I do want to mention that it's important to talk to your doctors, your primary care doctors, and let them know what you're feeling, and don't be shy about addressing these issues if you think it's new or it's a concern. It's better to be reassured and to address it rather than keep it to yourself.
Yes, I agree entirely. I think, as providers, oftentimes our interactions with all of you are pretty limited, right? So we learn about you within a couple of minutes, but you're in tune to your body and to your life for your entire lifetime. So trust that gut of yours. And if you feel like something is off, I always tell my patients it's better to be safe. Come on in. That's what we're here for, to answer your questions. And then we'll figure out, what strategies we need to employ to figure out if your heart needs to be checked out and in what way. Awesome, guys. Great. Okie dokie. So let's move on to our second question. Dr. Patisapu, this is directed for you. Can you discuss atrial fibrillation? What is it? What are, kind of the most predominant causes, life expectancy, diet and exercise recommendations? A loaded question, but I know you got this.
Yeah, so that's a very good question, and we see this quite a bit. Atrial fibrillation, or AFib, is a very common irregular heart rhythm disorder. Probably about 1 in 10 people after the age of 80 have some sort of AFib, either it's a continuous or paroxysmal, which is off and on. In the normal heart, we have 4 chambers, 2 top chambers, 2 bottom chambers that beat in a sequential fashion. When we talk about atrial fibrillation, it's usually where, instead of it coming from your normal pacemaker of the heart at the top right, it is in a chaotic fashion. The heart is beating from the top, with many different areas that are just firing off. And this can happen for a variety of reasons. When we talk about causes, and this is what we try to look for when we first see somebody with atrial fibrillation, is what may be driving it. Usually, most commonly, it's age. As you're aging, electricity of your heart kind of ages and gets fibrotic. However, there can be a multitude of things: alcohol, post-surgery, lung disease, intrinsic heart disease such as heart valve disorder, heart failure, blood pressure, infections, prior chemotherapy, kidney disease, genetics. So there's quite a variety of reasons that bring it on. When we talk about the main concerns, and I know you mentioned life expectancy, the main concerns we have with atrial fibrillation is, one, your heart is a muscle. So if it's beating too fast, it can get weak and get kind of tired. And so that's something we want to watch out for, make sure the rate is controlled. The other concern is what I kind of addressed prior, is the cause. What is kind of driving this? Is there something we can do about that? Is it because your blood count is low? Is it because you're dehydrated? Is it your blood pressure, sleep apnea? But the other thing we always talk about, and I know some may be knowing about blood thinners. So the main risk we also worry about is stroke, given the irregularity of the heart. And so it's important to address that to prevent stroke. And so you mentioned life expectancy as well. The main concern we have is people can live a pretty normal life with atrial fibrillation as long as we're able to treat the rate, as long as we're able to monitor your heart to make sure it's not getting weak, and also to address those underlying issues and prevent stroke. Most people live a normal life, and reassuringly, we have a lot of treatment options available. You mentioned diet itself. It's very similar to living a healthy diet such as a Mediterranean diet, low salt intake, avoiding alcohol. If you're placed on a blood thinner such as warfarin, maybe adjusting a diet or keeping track of your blood levels, what we call an INR. Exercise is also beneficial. Weight loss has been beneficial. But ultimately, it's also working with your doctor to find the right therapeutic approaches. Like I said, we have a myriad of options we can use to treat it.
Thanks so much. Yeah, atrial fibrillation is a huge topic, and I definitely want to get Dr. Mattina and Dr. Lake's comments on AFib, because I feel like we could have a whole panel on this arrhythmia. So, Dr. Mattina, do you mind commenting a little bit on this anticoagulation bit? I think there are probably some people out there in our audience who have questions about blood thinners, and when are they indicated, and do we really have to always be on Coumadin? What else is out there?
Sure. Well, we do have several options available for blood thinning medication. So the first thing is determine who is the appropriate candidate. We have a risk score that we use to calculate how much more increased your risk of stroke is because of atrial fibrillation over someone that doesn't have atrial fibrillation. And that can include risk factors like hypertension, diabetes, age, history of heart failure or other vascular disease, or if you've had a stroke before. So the more risk factors you have for stroke, the higher your risk is for stroke with atrial fibrillation. And for most men, once you have 2 or more of those risks, we're going to start anticoagulation. And for women, that will be at 3 or more of those risk factors that will start anticoagulation. In the grand scheme of things, most of the blood thinners are pretty efficacious at reducing the risk of stroke by about 60 to 70%. However, there are definitely advantages and disadvantages, different types. Coumadin, for one, or warfarin is very cheap, covered liberally by all insurance plans, but it does require monitoring. It's longer acting. You have to hold it for a longer time before procedures. But there's a definite way to reverse it if it runs too high or if we have bleeding problems. Some of the newer agents, which many in our audience may have seen commercials for, like Xarelto and Eliquis, all those things, they are also quite effective. And the advantage is they don't require blood test monitoring for the levels. You just have to take them consistently. So those can be good for people that are really good about taking their medications and not missing doses. They're reliable so that we know that they're always covered, because when they're more short acting, when you skip or miss a pill, you're not being protected from stroke. So I always sort of ask, is it the right patient? Is it the right type of medication? Obviously, cost does sometimes factor into our decision making.
Thank you. And, Dr. Lick, I wanted to ask you, what happens if, someone has atrial fibrillation, they do have elevated risk for stroke, but they can't tolerate blood thinners? Do we have options for them?
Yes, so there is a procedure that's called Watchman. It's a procedure where you can actually put a device in a part of the heart that's called left atrial appendage. It's the part of the heart where most of the source of stroke can be attributed to. It's a small outpouching from the left atrium, and the procedure is supposed to be simple. It requires probably a day or two in the hospital, and it's an outpatient. It's not an open heart surgery. This can actually reduce your risk of stroke significantly. So this is definitely an option if you are absolutely unable to take anticoagulation. Some of our patients who have had bleeding issues with anticoagulation or simply just had reactions and unable to take anticoagulation, we have referred those for Watchman, and I believe main campus does it. We at Akron General, we have been doing it as well.
Yes, exactly. That Watchman device can really be a saving grace for many patients. I always like to think of the left atrial appendage as like the chicken wing of the top left chamber of the heart. That's kind of an easy way to visualize it. As a sports cardiologist, one of the big questions I get about AFib is AFib and exercise. Is it safe? Is it not safe? And actually in individuals who have atrial fibrillation, perhaps paroxysms or waxing waning atrial fibrillation benefit from exercise. Exercise has been shown to reduce the frequency, the intensity, the duration of atrial fibrillation. So, overall for cardiovascular health, particularly because atrial fibrillation tends to be a consequence of something else going on, we really should continue to move our bodies intentionally. For athletes, and this may speak to several of you in our audience, there's been kind of a bit of a controversy about whether I should say probably high duration of endurance activity, so decades of endurance activity, whether that can precipitate atrial fibrillation. We do see that in a lot of highly competitive athletes. Sometimes they have paroxysms of atrial fibrillation, but that is no reason to not continue to exercise. AFib tends to be more of a nuisance that we can manage versus some of the abnormal heart rhythms that are deadly and can actually harm and kill you. And so, I again say, move that body. We're here to help control that atrial fibrillation to the best of our ability. Great, okie dokie. So let's move on to our next question. Dr. Lick, this one's for you. So this is a great question. I'm sure many of you have it. So what is the difference between shortness of breath due to physical activity and shortness of breath due to a blockage? With, for our audience, blockage referring to, obstructive blood flow through your coronary arteries.
So there are some differences. First of all, if you have a blocked artery and you're having shortness of breath, it is very likely that you're also going to have some degree of chest pain with it. So when I talk about chest pain, that's not going to be just like a minor discomfort that goes away quickly. It's going to be something that's more heavy, pressure-like, may radiate to the jaw, may radiate to your left side, also kind of makes you more uncomfortable and anxious. Most of the patients who actually do develop the symptom for the very first time, they'll actually know, or at least will be a little bit more alert to seek medical attention. But please be aware that sometimes if you actually don't know that you have coronary artery disease or blocked artery, you may not be able to notice the difference. I also ask patients if their activity level has been decreasing over time. So for example, if you were someone who were taking 3 flights of stairs and now over the last few weeks, you just can't even take a flight of stairs because you are getting so winded, that's a very drastic change. You may not notice it because it has happened over 3 to 4 weeks now, but you will start noticing if it keeps on getting worse. So overall, if you can't explain why you are getting short of breath without having any other change in life, if it's continuously getting worse, if it is associated with any kind of chest pain, I would be more concerned about having a blocked artery. And then there are ways to examine or work you up for that. The other thing I do want to mention is sometimes you can have shortness of breath that is related to heart issues, but that may not be a blocked artery. So for example, you can have leaky valve or a tight valve in the heart. Or you can have what we call atrial fibrillation. If your heart is too fast and you're having trouble getting all the blood pumped in correctly, you may have shortness of breath just because you're not getting enough oxygen to go into your body. The other thing would be heart failure. So if you have the pump of your heart is not really doing a good job giving blood to the rest of your body, you can actually feel short of breath. So those would be some of the other heart conditions that can actually make you short of breath. The other things that I mentioned, they may not give you chest pain along with the shortness of breath, but nevertheless, it can give you shortness of breath.
Great. Thank you so much, Dr. Like, I couldn't agree more. I think, if your shortness of breath tends to go away as your fitness gets better, that's probably a sign that that shortness of breath was that you were deconditioned, but always good to get it checked out if you're concerned. Dr. Martina, so you tend to see a lot of female patients as, kind of our guru of cardio obstetrics. What would you say in terms of our female patients? Do they present with pretty typical symptoms that could suggest a blockage or not so much? How would you characterize that group?
Yeah, I know there's a lot of press about heart disease presenting differently in men than women. Honestly, in my personal practice, I find the presentation is quite different. I feel even between men and women, there are just some people that are reluctant to call their symptom chest pain. They'll say, no, I never had pain. It's a pressure, it's a tightness. We're kind of splitting hairs on what to call it. But so I put more stock into how it happens, what makes it better or worse, is it progressive or not? In general, pain caused by blockages in the heart artery should get worse when you're exerting yourself. And then over time, if that were to progress, you may then have some resting pain because it has gotten worse over a period of time. But for the most part, there's going to be some progression. It used to happen just when I was really exercising hard. Now I just do a couple steps and I feel bad. And now I'm all the time feeling chest pain or shortness of breath. Women do tend to complain of fatigue a little bit more than men. So that's one thing I screen for too. And again, we're taking in sort of a whole body approach. So much of the cardiovascular system is tied to the lungs, to your brain health, to diet and exercise patterns. So at the same time, we're sort of screening for heart problems. I want to know, has your weight, if someone clearly tells me, I gained 50 pounds in the last 3 months and now I'm short of breath when I walk up the stairs, it's very likely that the weight gain is contributing and you're deconditioned. And so we should sort of work to address those things. There can be other times when someone's blood pressure is 200 over 110. You will have chest pain and shortness of breath just walking around when your blood pressure is uncontrolled too. So we want to work through all of the systems and make sure that we have any reversible causes treated appropriately. And then we'll continue our workup about blood flow to the heart.
Great. Yeah, even simple things like being anemic can sometimes make people pretty short of breath, and it's a very simple fix. Dr. Patisapu, what do you see in your practice? Do you see any differences, or what do you have to add?
Yeah, I couldn't agree more that there's a lot of times it can be multifactorial, especially in the older population. I do a lot of screening for not just heart blockages, but also anemia. That's one of the first things I check. Sometimes getting a heart ultrasound to make sure the valves are intact. When we talk about blood vessel blockages and shortness of breath, I find that that it is somewhat different from the one from activity, as you guys mentioned, that it's a little bit newer. It's a little bit where, hey, I was doing something just a couple weeks ago or just a month ago, and now I can't do that sort of approach. Regardless, when someone comes in my clinic, I try to keep an open mind because it's important to get a workup and also and also figure out what kind of system is going on. Is it the pulmonary? Is it the cardiovascular system? So regardless of has it happened or not in the past, or if you're young or old, there is some sort of importance of the clinical history and doing a little bit of a workup. And then, this is just a time point when you come in and, hey, we say your stress test was negative or your EKG was normal. That doesn't mean, the next 5-10 years that something isn't going to happen. That's important that this is a starting point to work on things, get physically active or change our diet.
Yes, it's an incredible opportunity to kind of start that cardiac risk stratification or risk reduction lifestyle if you haven't already. So a lot of fantastic points. I think the key takeaway is shortness of breath can really be anything, but we're here to help guide you with respect to, do we need to worry about it? Do we need to get you moving? And is it something else? Okay, Dr. Mattina, we're back to you. So this sounds like a personal question here. So this individual says, I have chronic idiopathic chest pain, which radiates deep into my left axilla. With stress tests, I'm told all is well. What are causes of chest pain? I worry a heart condition could get overlooked now that I'm a 70-year-old woman having that idiopathic diagnosis.
Okay. Well, this is a very specific question, and without knowing exactly all of the history and what workup has gone, it is a little bit hard to ferret all this out. You know, it's hard to, idiopathic, just for the audience, is mean that we don't have a great answer for that. And that we can sometimes get to that when we've kind of done an exhaustive workup from head to toe and not really found a good answer. It does not necessarily mean that the symptoms are not real. It's just that we have not been able to identify a cardiac cause. And in fact, a lot of our new guidelines now are telling us we're kind of changing the way we label this to be non-cardiac chest pain. That's to say that we don't know if it's coming from musculoskeletal or some kind of nerve pain, but it's not coming from a cardiac source. So there are several things, particularly in women, that we primarily, a lot of our testing, especially stress tests and heart catheterizations, when we're looking at blood flow, is looking at the epicardial arteries. These are the arteries that run on the outside of the heart, the big arteries. We have 1 million plus more smaller arteries, which is called the microvascular system, that run within the muscles of the heart. And they too can cause chest pain, shortness of breath, very similar to what major blockages would require, where you would need stents or bypass surgery. So this microvascular dysfunction can cause what we label as microvascular angina. So it presents very similar to someone having a heart attack. And in fact, women, more so than men, they can come with elevated troponin markers, like they're having a heart attack. They may have EKG changes. And then we do stress tests, heart catheterizations, and we see that the blood flow through the big arteries is normal. Up till now, we have very limited ways to evaluate the microvascular system, but we do PET scans sometimes, which can tell us about resistance to blood flow. And that gives us a clue about microvascular dysfunction. And the same risks apply for epicardial, big vessel disease, versus microvascular, small vessel disease. Chronic inflammatory conditions like lupus or some inflammatory arthritis, colitis issues can predispose you to that. Obviously, smoking or diabetes are also highly inflammatory things that can disrupt the microvascular system. So in general, you know, it's rare that I give up on a diagnosis of chest pain. You know, what we can say is it's not X, Y, or Z, you know, when we do our testing. And then still, we try to use medications. And for the most part, medications that work for angina, whether it be big vessel or small vessel, work the same. And so I would usually try some sort of medication that works to dilate all of our arteries to address the blood flow problems after I have done a workup to assess the microvascular system.
Great, thank you so much. Dr. Padisappu, what are some common non-cardiac causes of chest pain that you tend to see in your clinic?
Yeah, so Dr. Martina mentioned a lot of good points about the cardiac causes, and especially in our system, Cleveland Clinic system, we are doing a lot of further testing to get some of the newer diagnoses that we're catching now. When we talk about non-cardiac chest pain, you know, that's again after I've ruled out quite a bit, and I'm still a little bit suspicious. But a lot of times, lung issues such as asthma, COPD sometimes can cause chest pain. Nerve pain can cause it, as you mentioned. Something we call costochondritis, which is inflammation of the ribs. We can also have, you know, again, musculoskeletal pain. So those are the things that I tend to see. Sometimes we are also looking for inflammation of the heart lining, and sometimes that can cause chest pain. So there's quite a bit of different reasons. When I do see these patients, I don't necessarily let them go and say, hey, all is well. I do try to follow them, especially in our system, because as new advances come out, we can try to see what may be causing idiopathic chest pain, as you mentioned.
Yes, no, that's incredible. I mean, I think, in terms of other non-cardiac causes that we're really seeing even more frequently now relate to our post-COVID syndrome patients, a lot of them come in with, very typical cardiac symptoms, such as atypical chest pain. And I think, initially with the pandemic, we were worried about inflammation within the heart muscle or myocarditis, which we're really not seeing a lot of. The incidence is incredibly low. And this is kind of a testament to what you were talking about, Dr. Padisappu, with this potential neuropathy or nerve-mediated chest discomfort that sometimes is responsive to medications that are directed towards nerve endings. So it is interesting. I think other common causes of non-cardiac chest pain that can really mimic cardiac chest pain. Sometimes I have some patients who have esophageal spasm-like symptoms that are responsive to those little tabs that some of you guys may have that you put under your tongue, the little nitro, the sublingual nitroglycerin. And that can be a very easy mimicker of cardiac chest pain because it responds to those pills that we use for cardiac chest pain. So that can also be common. And then, Dr. Like, I wonder, particularly, I think I see a lot of women in my patient population. I imagine you also have a decent number of women coming into you. I wonder how many of these patients are coming in with symptoms that may be more akin to perhaps something related to underlying breast abnormalities. Sometimes I have patients who are pointing to specific parts of their chest. How often do you encounter that in your practice, if any?
I would say that in clinic setting, I think it's quite rare to have chest pain without having significant lump in your breast. I guess I have diagnosed breast cancer or cyst in the breast because not only did they have chest pain, but they also had a lump. I have never been able to diagnose breast cancer or lump without having a significant abnormality, which is a lump, and just having chest pain. I don't know if others have. I think it's quite uncommon that you would have chest pain before you would, develop some kind of abnormality. But one thing that I have seen quite commonly is how some people present with a clot in the lung, which is, in my opinion, a very, very serious thing to have. And sometimes, the EKG, the lab work is very similar to what you would have with a heart attack, and that can potentially miss your diagnosis. So those, in my opinion, are very big mimickers of heart attack. And I believe all of us have stories of patients that we have encountered who have come in with blood clots in the lung. And initially everyone thought, or even the patient thought, that they were having a heart attack. So that's one of those things that I've encountered more commonly than having breast cancer.
Yeah, that's an excellent point. And that also kind of goes back to our prior question talking about, causes of shortness of breath, because, sometimes people with clots in their lungs do present with that symptom. So I'm very glad that you brought that up. I think, that's definitely something we never want to miss. Any final points before we move on to the next question? Okay, I think we beat that one to a pulp. Okie dokie. So I love this next question because it relates to a lot of stuff that I think all of our patients have seen in the news pretty recently. It relates to the controversy of aspirin. So Dr. Padisappu, this one's for you. I keep hearing conflicting recommendations. Should I take a daily aspirin for my heart health? What are the benefits and risks?
That's a very good question. I think probably the past 10 years has gotten a lot of review, rightfully so. I think now aspirin therapy should be individualized for each person. First, when we're talking about aspirin used in the setting of known coronary artery disease or a prior intervention or a prior stroke or vascular disease, or your doctor had recommended for a particular reason, then aspirin is useful. And that is what we call secondary prevention, preventing a second episode. However, the main question probably comes from preventing what we call primary prevention, or preventing a first event of a heart attack or stroke. And it's been falling out of favor, and that's mainly due to the risk of bleeding. Newer data suggests that there may be a small benefit in using aspirin, but that's in the younger age population. between 40 to 60, 40 to 70, who have a higher risk of stroke or heart attack, such as diabetes, high blood pressure, smoking, a significant risk. But that comes at the main thing is that you should not have an increased risk of bleeding as well. When we talk about using aspirin for ages above 70, the data has not been so good because of a bleeding risk. And I think that's why it's falling out of favor, is bleeding mainly in the GI tract, but also in the brain, extracranial, intracranially. And then the other thing is it's compounded by the fact that a lot of days a lot of medications actually interact and can cause excess bleeding risk, such as NSAIDs, over-the-counter medications. So when you mix both of those two, that bleeding risk may outweigh that very small incremental benefit of aspirin. So now in my practice, I don't necessarily place it on a majority of patients unless they have a very high risk of a concern of a heart attack or stroke, and that's mainly in a diabetic population. And we do a lot of risk calculators. It's a 10-year risk calculator score that we try to use. And again, I try to be very proactive and make sure that there's no increased risk of bleeding.
Great, thank you so much. Dr. Mattina or Dr. Life, any additional comments you'd like to add about when it's appropriate to use aspirin, when we should avoid it?
I personally don't use aspirin for primary prevention, and really not in any patients, not in the diabetic. Since the statin trials have come out, I really think that you get the most bang for your buck with just primary prevention statin without the bleeding. I will say there is an indication for primary prevention aspirin use for prevention of preeclampsia in pregnant women. So especially women that have had other pregnancies with preeclampsia, if they're of African-American ancestry, obese, this may be advanced maternal age. Those are some risk factors that increase your risk for preeclampsia. So we do use aspirin 81 to 162 milligrams after 12 weeks of pregnancy through the duration of the pregnancy to help increase the blood flow through the placenta and reduce the risk of preeclampsia. So that is primarily the only indication that I use it for. Otherwise, it would have to be sort of a secondary prevention, stroke. There are sometimes people that may have blood clotting genetics that predispose them. And if they've had clots or a family member first degree, that might be another consideration for that. But that would be done in conjunction with hematology and vascular medicine.
Great. Dr. Like, anything else you'd like to add?
I 100% agree.
Yeah, and from a personal experience in terms of my practice, oftentimes we have imaging that is unrelated to the heart that may show some evidence of what we call atherosclerosis or cholesterol-laden plaque or heart disease. And that can be an indicator or a reason to use aspirin as a preventive measure to prevent some strokes and heart attacks. That's typically what I do in my practice. And I agree with you, Dr. Padasapu. I think we do see some increased risks of bleeding, particularly in our elderly population. So in those people who are above the age of 70, it's really, not necessarily a, kind of you must use aspirin irrespective of their heart attack and stroke history type of a deal. So definitely an individualized approach kind of goes into the lines of the trajectory of medicine with kind of personalized medicine and individualized medicine, which is great. Okay. And then actually one final thing I wanted to open up to the panel, we're talking about aspirin in the context of heart disease and prevention. Is there any role for aspirin in something like atrial fibrillation?
So in some patients, if their risk of stroke is not too high, like Dr. Mattina had mentioned before, you could consider aspirin instead of anticoagulation. But I always will have a very frank and lengthy discussion with my patients. Aspirin does not substitute anticoagulation in people who are deemed to be at higher risk of stroke. So if you are someone who is above the age of 65, have had stroke previously, have high blood pressure, diabetes, heart failure, etc. So those things will actually give you a higher risk of stroke, and you would be best suited for anticoagulation with something like warfarin or the newer anticoagulants. So aspirin will not substitute it. But in some patients, if the risk of stroke is not very high, if they just have high blood pressure, for example, in those patients, you could consider doing aspirin.
Yeah, this is pretty controversial, particularly with the electricians of the heart, our Heart and Rhythm Society. In fact, I think, I agree with you, Doctor. Like initially it was, we could give aspirin for very, very low risk of stroke individuals. And now I think they're favoring that there really isn't even a need for the aspirin. It's not really doing anything for you. So just, it's one of those common questions I think we all get in clinic, do we not, and so forth. Great. Okay, so on to some questions about prevention. So Dr. Like, this one's for you. Is it possible to be overweight and heart healthy?
So this probably goes back to the obesity paradox that we used to talk about so much. It's a debate, but I would start by saying it is possible, but that's usually not the case. So and the other point that I do want to make is that, yes, you can be obese or overweight, but not everyone will have the same risk of developing heart disease. So, for example, someone who has a body weight of 220, same age group, same guy, and then another one, they will not have the same risk of heart disease because it is determined by many other things, including your family history, whether you have high blood pressure, how much activity level you have, how much abdominal fat you have, because that also drives your true cardiovascular risk. But to end the debate, I would say that when your BMI is going to be in the higher range, it will definitely give you a higher risk of heart disease and stroke. So there is actually no second opinion on that one. But then your risk of heart disease at the same BMI may be different because people with similar BMI may have different activity levels, different risk factors, different family history, and may take care of themselves differently. Did that answer your question?
Yeah, and just to kind of make sure we clarify, so BMI is body mass index, which in my mind is a poor way to actually get a good sense of someone's body composition. So I do want to clarify, your weight is not reflecting body composition, and therefore BMI in my mind is moot. Dr. Matina, I know you're fired up about this one.
I was just going to make that same point, and that we're using BMI because it is quick and easy for us to do in the office. And really to measure body fat, we need to either do a DEXA scan, you got to get in your bathing suit and let us dunk you in the water, we got to do calipers and pinch you all over, which, as you can imagine, 20 to 30-minute office visits, you got to find parking, it's over. We're not doing that in an office visit. So we use it as a marker, but what we're really trying to get to is how much fat you have, and fat around the middle is worse. So a better marker, which we probably should do a better job of in clinic, is measuring central obesity, your abdominal growth. So for women, that should be less than 35 inches. So that's without your Spanx on, not sucking it in, full exhale around the middle where your waist is supposed to be. 35 inches or less for women and less than 40 inches for men. If we're having fat around all our internal organs, that's what increases our sort of insulin sensitivity, predispose us to diabetes and heart disease risk. And I will say that most of the data, as Dr. Singh was pointing to for BMI, why it's a poor marker is because it was validated in Caucasian men and women. And so we do know that it does not reflect well in other ethnic groups. So for instance, BMI can carry a higher risk of heart disease at a lower BMI in Hispanic or Asians. And really, we don't start to see that trend in higher heart risk until BMI is above 32 or 34 for African-American men and women. So really the answer we want to get is, yes, you can be overweight. What we're trying to answer, are you fit, right? So can you be fit and overweight? Yes, you can, right? And we still want to work through a primary prevention strategy. Just like the American Heart Association says, we have sort of 7 markers to know if you're in ideal health. So not smoking, making sure blood pressure is controlled, sugars are controlled, lipids are controlled, you're eating a healthy diet, sleeping well, and exercising. So yes, you're going to prolong your life if you're doing all of those things right, and we're really working on reducing fat content in the body.
Perfect. Excellent. Excellent. Dr. Padisapu, anything you'd like to add to that?
No, I think they hit it right on the spot. Dr. Martinez, straight to the point, and that's important for our patients to to realize that and learn that it's important to also realize, is it correlation, causation, or both? And as Dr. Martina said, there's more than just the weight. There's also the physical activity level, the smoking, is it diet? Is there other things that are confounding that factor? So I agree with all of that.
And I'll just add one more thing, is that we actually have a lot of data to say that women don't go to doctor's appointments because they don't want to get weighed. And so I think this is a great disservice, and we have to sort of dispel this myth, right? And I have women that come in and they refuse to get weighed because they're like, I don't want to know, right? And just like anything, you can't fix a problem unless you identify it, know what it is, stages of denial or not. We're not judging you. Look, even as physicians, many of us are not meeting all 7 of those guidelines. Okay, we're people too. We're working men and women, have children at home, other responsibilities. So we get it. It's hard to do all the things we're asking you to do. So no one's judging you. We want you to come in and get the advice, and we're willing to work out a plan with you that's going to work for your lifestyle.
Yes, I can't echo that sentiment enough. It's just a number. That number on the scale does not define you. It is just an unfortunate metric that we have to document, if that helps. So just again, focus on, kind of the holistic approach, being intentional about what you're putting in your body, how you're moving your body, and we can help you figure out, whether or not weight is an issue and how that will reflect in terms of your heart health. Okay, so the next question is on exercise, which is near and dear to me. So I'll tackle this one. So this is another audience question. As a healthy 50-year-old woman, when exercising, how do I recognize a good pounding heart and little dizziness versus overexertion? As I age, do I need to be concerned about exercise actually contributing to heart and stroke event risks? So this is an interesting question because, the person here is describing that they're having pounding heart sensations and dizziness, which in my mind could be symptoms for someone, symptoms reflecting something that's not right, versus overexertion. And it can be challenging. What I typically say is when you are exercising, some people are a little more attuned to feeling their heart rate. Most people are not. And you will notice a level where you are huffing and puffing if the intensity of your exercise is high. So I usually will ask, does your level of effort, is your level of exertion concordant with, kind of your breathing, your expected breathing, or are you huffing and puffing when you're, maybe walking very, very slowly and, feel like you can't go any further? In terms of the specific dizziness with exercise and pounding heart, if you're feeling dizzy with exercise, lightheaded, like you're going to pass out, that's not a good thing. The last thing we want is for you to be walking on a treadmill, hit your head and pass out as a result. So those are, what I call red flag symptoms, where I would in fact have patients come in and be evaluated and figure out, what we need to do to work that up a little bit. And then finally, does exercise actually contribute to heart and stroke event risks, and when would you need to be concerned? Now, for the most part, exercise is incredibly beneficial to reducing cardiac risk and stroke risk, so risk of heart attacks, risks of strokes, because exercise helps to control a lot of those risk factors. It reduces your blood pressure, it helps to reduce your cholesterol, it helps to improve blood sugar control to prevent diabetes, it helps with weight management and obesity management. So, exercise is nearly always a good thing. There's really very few cases. One in particular comes to mind, a familial abnormality with the heart muscle specifically, where progressive and ongoing exercise may lead to more rapid progression of disease. It's a loaded term, arrhythmogenic cardiomyopathy, very rare and again genetic. But for the most part, exercise is very beneficial for the health of your heart and the health of your blood vessels. I think just to get to the crux of this question, when to be concerned is, again, when you see some discordance in what you're feeling with the level of exertion, and then, chest discomfort, chest pressure, chest pain with exercise. Sometimes I describe, or ask questions, is your heart rate going really, 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 really fast, causing you to feel like you're hitting a wall? Are you feeling some irregularity in your heartbeats causing or associated with shortness of breath or dizziness? So it's, again, a dialogue between provider and patient to just decipher, do we need to be worried about this or do we not? So I spoke a lot about that question. I'm going to open it up to you guys. Dr. Like, anything you'd like to add in terms of, when does exercise Is it good? Is it bad? And, when should we be concerned about, symptoms or quote unquote symptoms with exercise?
So exercise is always good. That's the first thing. It's always good. And you also pointed out earlier that even in patients who are very scared of their atrial fibrillation, getting to certain point should also not be scared of it and keep on challenging themselves. The only time I will ask patient to watch it a little bit more carefully is if they are having new symptoms. So if you are someone, for example, who had previous bypass and suddenly you're calling me or you're coming to the clinic and you have new onset chest pain that is concerning you, I would probably ask you to slow down your activity level a little bit until we evaluate you, because I don't want you to have, next thing happens, you're having like more severe chest pain. So until we have a good cause identified, I would probably ask you to slow down a little bit. But that's probably one of the only situation where I will caution you. But most of the times, if you can tolerate it, this is what I tell my patients: do as tolerated and challenge yourself as much as you can. And that's a good rule to follow.
Yeah, and that also speaks to, oftentimes I'll get a question is there a specific heart rate that's too high for me? And heart rate is just so individualized. Oftentimes we have the benefit of a stress test to see what someone's maximum heart rate is, but heart rate can be affected by things like hydration, anemia, diet, infection or illness, poor sleep, all those things affect heart rate. So, they're really, at least, in how I counsel my patients, there's really no maximum, but there can sometimes be some thresholds that we put based upon someone's underlying disease and cardiovascular risk. Dr. Martina or Dr. Patisapu, anything else you'd like to add?
No, I think one thing I commonly tell my patients when they ask me about, is it okay to exercise? I point to the fact that, even when we do open heart surgery, the first referral before you even leave the hospital is to cardiac rehab for supervised exercise. So if we can slice open your chest and rearrange all the stuff in there and tell you to exercise, most other things are going to be okay too.
Awesome.
Yeah, and I agree. Though one other thing is, a lot of patients now and people have been good about having certain watches or devices that kind of tell their heart rate. So that actually helps me a lot, is knowing if the heart rate comes down appropriately. So after exercise, does it come down? And also, you mentioned the I think dizziness, and it's also important to ask, is it dizziness other times as well, or is it just with the exercise? And Dr. Singh, you mentioned, apart from a very few certain indications where we don't promote exercise as much, exercise is generally well tolerated and beneficial for pretty much everyone.
Awesome. So I know we're kind of getting close on time here, so I'm going to try to whip through a couple of more questions because they're also excellent. I wish we had the entire evening to talk about them. So, Dr. Martina, this is a great question. What special heart care is needed right after menopause, especially since heart disease runs in my family?
Okay, well, still the average age of menopause is going to be about 52, 54 for most American women. So we do start to see heart disease trends that increase about 10 years after menopause, when all of our estrogen stores are pretty much depleted. This can cause changes in your cholesterol, which may mean a rise in LDL, which is the bad cholesterol that is associated with heart disease, and a decrease in your HDL, which is our good protective cholesterol. So we want to make sure that we're screening for cholesterol levels, we're following a balanced diet. Also, as we lose that estrogen, our blood pressure tends to go up and our arteries get more stiff. So I often have 60, 65-year-old women who said, I've never had blood pressure in my whole life. And then the gift of menopause gives them elevated blood pressures. And so we may have to treat that at that time. And then for the most part, it does get harder to maintain your weight in menopause. Maybe the physical activity you were doing, in your 30s and 40s, you might have to do more, expend more energy because those calories are just not coming off. So that can be frustrating for women. So that's something we, have to sort of work on, maybe some changes in your diet or changing the activity to include some higher intensity levels, or a different form of exercise that they're not so conditioned to already.
Great. Anything else either Dr. Lick or Dr. Patisapu want to add before we move on to the next question?
She answered it very well.
Yeah, she hit the nail on the head.
She knows a lot about this topic.
Perfect. Okie dokie. So Dr. Patisapu, cholesterol. So is it true that it's okay for your bad cholesterol numbers to be high as long as your good cholesterol numbers are high as well?
That's a very good question, actually. That we see that quite a bit, that question. First, the definition of bad cholesterol is probably multiple types. You may see it on your reports. LDL, direct LDL, there you may see VLDL, LDL particle size, ApoB, even triglycerides. When we talk about good cholesterol, we typically mean HDL, which helps remove cholesterol from the blood back to the liver to get rid of. Now for the question, this is not entirely true. LDL and other similar particles I mentioned before have its own significant effect of increasing adverse events, regardless of the HDL. HDL is slightly more complex in terms of cardiovascular events, but generally speaking, the higher the HDL, the better it is. A goal probably for men above 40 and women above 50. It does have a protective factor, but that's also, is it because people with HDL exercise more or have healthier diets? Not entirely sure. However, in the clinic, I typically focus on LDL and those other bad cholesterol particles because those are the proven research medications that we use on a daily basis and that we have followed that have improved morbidity and mortality. If your LDL is not significantly high, but there are other concerning risk factors, we do look for those other particles that I mentioned, those other bad cholesterol particles. But again, I think primarily I try to focus on the bad cholesterol and lowering that. And I would not say that one negates the other.
Great. Wonderful, wonderful. Dr. Light, so this question is one we would never have asked until March or February or however of 2020. I can't remember anymore. What is the impact of COVID infection on the heart?
And I'll tell you, the answer has changed drastically over the last 2 years too, as we have come to know more and more about COVID. And now we're dealing with more the post-COVID syndromes as well. So COVID-19, since the pandemic started, it has kind of opened our eyes to how much kind of impact on the heart it has. Initially, we were puzzled with, why patients were presenting a certain way, but now we know a lot. There has been, even in Cleveland Clinic, we have had a paper last year that emphasized on how patients with COVID-19 infection can actually develop what we call broken heart syndrome. And it's a very interesting phenomenon, and really, we have known about broken heart syndrome. The other name for that is Takotsubo cardiomyopathy in patients who undergo through stress. So it was previously reported in people who were undergoing major stress, divorces, death of a spouse or a loved one, financial constraints, etc. And we saw a higher number of COVID-19 induced Takotsubo or stress-induced cardiomyopathy, just because it does put a strain on your mind and the heart. The other thing that has been reported with COVID-19 would be inflammation of the heart called myocarditis, can present with chest pain. It can definitely damage your heart muscle, which can either be permanent or can get better with medications. We have seen quite a few numbers of that. And that's a very potential complication. COVID-19 infection also increases inflammation and can actually give you a higher risk of heart attacks and strokes. It also has that impact by, in simple words, making you more thromboembolic, making you more prone to throwing clots, etc. So you can have more heart attacks, strokes, etc. in patients who have had COVID-19 infection. Those are some of the things that come to mind. And if you have anything else to add, those are the major ones.
No, I think you summed up many of the major points. And again, we could have a whole another hour discussion long on COVID and the implications on the heart. So thank you for sharing that. So we have time for one more question. We had so many great questions. We didn't really hit anything on nutrition. Whole foods, unprocessed is the way to go. But our final question, Dr. Padisappu, if you can bring this home for us, if there's one major thing I can do to protect my heart health, what is it?
I wish I can go on and on. We have so much that we could do. I think, we've made significant advancements in cardiovascular medicine, such as medications, procedures, imaging tools, interventions. I think by and far, research has proven time and again, staying active and reducing your idle time sitting has continued to be one of the most important factors in protecting your heart health, not just for cardiovascular disease, for kind of all general health. Your ability to exercise and stay active is actually a much better prognostic factor compared to those that are less active, despite having an abnormal stress test or having known blood vessel blockages or having heart failure. And so by that, I think saying that the goal is just to slowly improve your exercise or activity level every day or every week. You start slow, 5 to 10 minutes a day, carve out time to call it exercise, and work up as your time permits. Like I mentioned, this will not only assist with your heart health, but research has shown that exercise and activity level improves many other non-cardiovascular disorders.
Dr. Mattia, any last comments on that question from you?
Sure. I would say really knowledge is power. So you can't tell what someone's heart health is by looking at them on the outside. So you need to know your risk factors, know what your blood pressure is, what your hemoglobin A1C or your fasting sugars are, know what your cholesterol levels are. Are you getting at least 150 minutes of aerobic activity weekly? Are you sleeping and managing stress? So if you can check off all those things, because many times people tell me, I'm active, I do this, I do that. And, doing housework does not make you fit, so fitness is a different measure. We want to make sure that you're actually meeting all of those benchmarks for that. And just because you're skinny doesn't mean you're healthy either. So we really want to make sure that you know all those numbers. And the more you know about your family history or other predisposing risk factors, as we mentioned before, chronic inflammatory conditions, any pregnancy, adverse pregnancy outcomes that can increase your risk in the future, family history. If you know more about that, that's going to help reduce your risk because we can identify risk and treat it sooner.
Yep, exercise is intentional physical activity, not just being active from a day-to-day basis. Dr. Lake, bring this home for us.
I cannot say it more. I agree, knowledge is power. So if you know what your true risk is, I think you're more likely to make changes to your lifestyle. It is sometimes surprising when people, even in their 40s, 50s, and sometimes in 60s, have never been told that they had high blood pressure. Their first visit may be in their 40s and 50s, and they're not aware that they had high cholesterol. So it's always good to have that check and be aware of your risk factors.
Yep, exactly. We want to see you. So, we're here to help you, not judge you. And like everybody said, I always wrap it up with my patients by saying, be intentional with what you put in your body and how you move your body. And consistency is key. Take it day by day and just be mindful. And I think if you follow that practice, you're going to find that, it's much easier to tackle some issues with heart health and whatnot. So with that, this concludes our Cleveland Clinic Ask the Experts event. Thank you so much for attending. We definitely had a blast. High fives virtually all around. We'll send you a post-event email in the next day or so with some important information about what you just heard here with us. And it'll include a lot of links about heart healthy resources, details on how to make an appointment. It'll also include a link to this recording, so you can view it again and again and share it with your family and friends. So with that, thank you so much. Please, everybody, stay safe, stay healthy, stay warm, and good night.